Okay, what's up, everyone? Super excited that you're all here today. We have some of my favorite people from residency here joining us. Well, actually, residency and fellowship joining me today. Before I get started, I just want to turn it over to our case presenter today, Allie. I'll let her just kind of introduce herself, and then I'll turn it over to our discussant, John. But I'll let you guys take the stage.
Hi, I'm Allie. I'm a PGY1 categorical medicine intern at Emory. I'm from the Philly area. I just moved down to Atlanta this year, and I'm excited to be here.
Awesome. Thanks, Ali. Thank you guys all for the invitation. So my name is John Huang. I'm currently one of the second year ID fellows over at Emory. By brief way of introduction, I'm originally from DC, Maryland area, and then I came down here for residency, did a chief residency over at Midtown. And now I'm doing ID fellowship with a focus in transplant infectious diseases. And just for context as to why I wanted to do infectious diseases, I love the clinical reasoning component of it. Love working with immunocompromised hosts, and it's one of the best fields for like multidisciplinary approaches. And so I love my discussions with my pharmacists, my surgeons, my medicine teams. It really does feel super collaborative in ID, and happy to mentor or talk to anyone through the ID process. So thank you guys for the invitation.
Hi
Nice.
guys. Oh, hey Dan, thanks for introducing everybody. Hope you guys can hear me okay. I'm so excited to be facilitating today with two of my favorite people, John and Allie. Allie's actually my intern right now on wards, and we're super excited to share this case with you guys today. Marcella, whenever you can, do you mind sharing the screen? And we'll get started. Awesome. Okay, so we have a good case for you today, some teaching points, some bread and butter. So I'll let Allie kind of take it away and we'll start with the chief complaint.
All right, sounds good. Thanks. So, the chief complaint, we have a 73-year-old woman here. She's presenting with progressive chest pain after a fall last week.
So John, probably not what you were expecting as a chief complaint for ID, but we just love to hear from you what you kind of think of when you hear this patient come in and if something starts triggering in your ID brain.
Yeah, absolutely. And so not much immediate ID information. I don't hear anything about fevers, chills, any localizing symptoms. Don't have a ton to go off of from the ID side, but usually how I approach the initial presentation, I first look at the host. So 73-year-old, we unfortunately don't really have a ton of past medical history, which I'm sure we'll hear about more in the future. But I look at the host, 73-year-old, no obvious like immunocompromising conditions is one of the first things I think of. So history of HIV, history of, for instance, CVID or recurrent infections. Nothing immediately is jumping out in terms of an immunosuppressed patient, but I'm sure we'll get a little additional history with the past medical. And then in terms of kind of the initial presentation, chest pain after a fall, obviously the first things I think about is this trauma related. Thinking through kind of a chest pain differential as a general internist, infection is usually not the first thing I think of, but thinking through like cardiac risk factors, could this be cardiac related? Could be pulmonary related, like a PE, ACS, a dissection, pneumothorax. I mean, those are kind of the red flag things that we don't want to miss in a patient and in an elderly patient with chest pain. So immediately thinking of non-infectious things, but thinking through kind of an infectious approach, like could there be some kind of sepsis driving some type of fall, some kind of syncopal episode, some type of infection causing hypotension in a fall. And then in terms of maybe residual from a fall, I mean, I think of like traumatic incidences introducing bacteria to the area. So could they have a skin and soft tissue infection in the area? Could they have osteomyelitis? Could they have mediastinitis from some type of traumatic injury that introduced some type of bacterial process into the area? And so those are kind of my initial thoughts. Without any additional information, I don't really have anything else to localize it to a clear infectious syndrome. Like the infectious syndromes I typically think about, CNS infections, skin and soft tissue, pulmonary infection, urinary infection, like a UTI. Nothing is immediately jumping out at this time. And so I think a little additional information will help kind of broaden our differential and help focus our thinking.
Awesome. Thanks, John. A lot of itises that came to mind already for you. Okay, Allie, you can give us more information.
Okay, so she tells us that that last week at the dermatologist's office, she had a skin biopsy of the left breast, no complications after the biopsy, and she was discharged home. She describes the chest pain as intermittent, non-radiating, near her left breast, and worse with movement. She doesn't have any fevers or chills. And the only thing that's positive on review of systems is urinary frequency.
It's interesting. Again, nothing immediately infectious jumping out. I'm sure we'll get a little bit more details moving forward. But in terms of the additional information that we have, a skin biopsy, and anytime I'm thinking from an infectious standpoint, if the presentation kind of correlates with a recent procedure, surgery, skin biopsy, I always think, could there be possibly some kind of infectious complication related to the procedure? And so thinking about a skin biopsy, which tends to be quite benign, certainly if depending on how it was performed, if there were any complications where you could develop a skin and soft tissue infection, an abscess, some kind of tracking infection from the site of the biopsy is one of my immediate thoughts. They mentioned no obvious complications, and then the chest pain is intermittent, non-radiating, and it seems to kind of localize again to the area of the skin biopsy. And so really start to worry, is there something potentially associated with the biopsy as a potential complicating factor? Doesn't have any fevers. And then on review systems, you also mentioned urinary frequency. And so this is a common consult on the infectious disease side. Like, is there a UTI component of this? Like her only symptom is urinary frequency. So I'd definitely be concerned and wonder if she has any abnormalities on her UA, any evidence of pyuria, any bacteriuria. But it's a little hard to kind of tie into the clinical presentation a distant UTI and how that would be related to the chest pain in the fall. So I don't think that those two are necessarily related, but we don't have other review systems to work with. So things I'm thinking about, given the proximity of the symptoms related to the recent biopsies, is there some kind of complication related to the breast biopsy, like some type of tracking skin and soft tissue infection may have had a deeper infection as a result of the trauma to the chest. But otherwise, nothing else really seems to localize, and the possible frequency, trying to tie it in a little bit, but don't see an immediate connection at this time.
Thanks, John. And I was going to ask you, because you said that you enjoy thinking about immunocompromised hosts. Let's say that this patient had a biopsy for cancer and it was positive. I'd love to hear from you kind of the scale that you think about people being immunocompromised and where malignancy falls on that.
Yeah, that's a great question. And so how I've always been taught in terms of degrees of immunosuppression, we always have to think of like, what is the effector that is being targeted with this degree of immunosuppression? So the big buckets that I think about, a la Varun Fadki, if you ever had a chance to rotate with the excellent clinician educator that is Varun, we separate into adaptive immune system versus kind of innate immune system. So our innate immune system, we think of like our skin barrier, we think of our neutrophils, our macrophages, like the immediate cells that activate as soon as there's some type of infectious or some type of inflammatory process. So those are kind of the innate processes. And then kind of the adaptive immune system, we think of our T cells, our B cells, our complement tends to be more innate, but more of the T cell, B cells that need to be activated to prime in fighting infection. And so those are the kind of the different broad categories, I think, of effector cells that are affected in the setting of immunosuppression. So innate immune system, neutrophils, macrophages, versus adaptive immune system response like T cells, B cells, and then tied into that is like antibodies and those kind of things as well. And so malignancy as a broad category, I usually think of and differentiate solid organ malignancies. So like breast, colon, any of the organ systems being solid organ versus hematologic malignancies like leukemias, lymphomas, which the abnormal cells are really the blood cells directly. And so with a typical kind of solid organ malignancy, I honestly don't think of those as being severely immunosuppressed in general, in the absence of chemotherapy or some type of targeted treatment. And so in the absence of any type of chemotherapy or any kind of immunotherapy, like CAR T cells, for instance, I don't think of the solid organ malignancies as particularly immunocompromised. Now, it's very different if they have different type of different types of chemotherapy, which may end up affecting your neutrophils or may end up affecting causing cytopenias. And so those things are kind of a different story when you look at the different types of immunosuppression that occur following chemotherapy. But in general, I think solid organ malignancies tend to not really be severely immunosuppressed until they get some type of chemo. Or if the solid organ, if the tumor is causing some kind of bone marrow infiltration, that's kind of a different story. But in the absence of bone marrow infiltration or chemo, I don't really regard them as severely immunosuppressed.
Thank you, John. That was amazing. Allie, you can actually go on and maybe give us some more past medical history for this patient.
Okay, yeah. So for her past medical history, she does have a history of breast cancer, status post chemotherapy and radiation. She has CKD2, she's got type 2 diabetes, hypertension, COPD, and osteopenia. For the medications she's taking, she's on metformin, insulin, carvedilol, atorvastatin, hydrochlorothiazide, gabapentin, and alendronate. Her family history is significant for diabetes and heart disease in her mother and sister, and stroke in her father. She's never smoked. She doesn't currently use alcohol. She's never used any other drugs, and she doesn't have any allergies.
Awesome. That's a lot of great information to work off of. And so some of the immediate things I think of from the infectious disease side. So now we know breast cancer history, chemo. And so one of my immediate thoughts is like, what type of chemo did she get? How recently did she get the chemo? And were there any known complications related to chemo? So one of the fun things about ID is we have to know a little bit about kind of every subspecialty. And so having a little bit of familiarity with what the chemo regimens look like and if she had any complications. But certainly, potentially, some of the chemo regimens may have made her immunosuppressed, in particular with some of the novel immunotherapies associated with breast cancer. And then radiation itself can cause a lot of like fibrosis and skin scarring, can also lead to anywhere that the radiation penetrates can have some degree of scarring. So I think of like pericarditis, pleuritis, any type of itis within the range of the radiation therapy. So could that be potentially contributing? Some patients I've also seen have very severe esophagitis. And so any kind of itis in that area of the chest is a consideration for non-infectious causes. But depending on the chemo can certainly predispose her to certain types of infections. And then other things you mentioned, looking through her medications. Another question I have is how severe is her type 2 diabetes? Because that certainly can be an immunocompromising factor, just having severely uncontrolled type 2 diabetes. Like for instance, in patients with really high A1Cs, with really like, above 13, 14, 15, they may develop some type of neutrophil defect. And so in those situations, they predispose to things like you commonly think of like mucormycosis or mucor associated with patients with uncontrolled type 2 diabetes because they have neutrophil defects that can't fight off certain types of molds. And so I'm curious about her insulin regimen, how severe is her type 2 diabetes, and if that potentially also predisposes her to some type of infection. Other things, nothing immediately jumping out tying into infectious disease, but really great detail so far.
Awesome. Thanks, John. Yeah, I love the discussion about the type 2 diabetes. I feel like we see so many patients with that, especially older adults, oftentimes uncontrolled, sometimes because of polypharmacy or sometimes just because they're not taking their insulin correctly. So a great way to tie in infectious disease when you see some of these patients. And then Allie, do you have that information about when her last chemo was and her A1C?
Yeah, so her A1C was 8.5, and she finished chemotherapy in 2017.
Got it.
Okay.
Yeah, A1C is not severely uncontrolled, so I wouldn't necessarily expect her to be severely immunocompromised based on just the diabetes. And then the chemo, 2017 seems a little distant. Certainly, as the chat had mentioned, like it could be like doxorubicin, daunorubicin, something that has cardiotoxic properties as a consideration. Do you happen to know what the chemo regimen was off the top of your head?
She did get radiation and she got anthracycline therapy.
Anthracyclines, okay. Got it. Anthracyclines, I don't immediately think of in causing abnormalities with the bone marrow. I know it's more associated with kind of cardiotoxicities and those kind of things, but would not be immediately concerned about that contributing to risk of infection, especially given distant administration.
Awesome. Thank you so much. And then John, whenever we're looking in the ID notes, we always say things about people's pets and travels and hobbies. Is there anything particular that you think you would be asking this patient from some of those extra ID special questions?
Yeah, that's a great question. At least looking through the presentation in terms of, chest pain, recent skin biopsy, some urinary frequency, honestly, nothing. I would certainly advocate for everyone to do a very complete social history. You can certainly pick up on risk factors. For instance, getting a good sexual history might increase your risk for HIV or syphilis or some type of STI that I can't quite tie into the current presentation, but I would always advocate for a detailed social history, just because you never know what risk factors you're going to uncover that might help contribute to the case. That might not necessarily be related to their current presentation, but could potentially help diagnose HIV or help in other parts of the clinical case. But from what I'm reading through and what we've discussed, nothing immediately jumps out from pets or social behaviors that I'd be particularly worried about related to this presentation.
Awesome. Thank you so much, John.
Of
Okay,
course.
Ali, why don't you tell us how our patient looked when you saw her, some of her vitals and her physical exam when you first evaluated her?
Sure. Yeah. So as far as vitals, her blood pressure was 139/62. When she came in, she was a little tachycardic, heart rate in the like 103 to 110 range. Her temperature was 103 um, Fahrenheit. Her respiratory rate was 21, and she was satting well on room air, 96%. On exam, she wasn't in acute distress. She was maybe a little bit sweaty. She was alert and oriented to time, place, situation. Um, Her heart exam was normal, regular rate of rhythm, no murmurs, rubs, or gallops, um, no pericardial rub, no lower extremity edema, pulses throughout. And her pulmonary exam was normal as well. No crackles, no wheezes, no sounds of consolidation. Her abdominal exam was soft, non-tender, no suprapubic tenderness. And then for her skin exam, there was some erythema over the left breast, tracking up along the left side of her neck. There was no fluctuance. It was warm over the biopsy site. There was no lymphadenopathy. As I went to sort of move her left shoulder, she really resisted motion. It took a lot to kind of get her to be willing to move her shoulder, to look at to see if there were any lymph nodes under her arm or any skin breakage. But she was pretty uncomfortable moving her shoulder. She wasn't necessarily tender to palpation. She was tender to kind of deeper palpation. It was warm over the anterior portion of her shoulder, but cool everywhere else. And I wasn't able to feel any effusion. There was the biopsy site I took a look at. It was covered with a Band-Aid. The Band-Aid had a little bit of drainage on it, and it looked dark, but not necessarily like not purulent. And then the other thing that she had um, was a rash, like an intertrigo rash in the groin area, with white plaques.
Awesome. Thanks, Sally. And the only thing I'll add to that, Allie mentioned it a little bit, it's like she was having a lot of neck pain and she could barely move her neck horizontally when we saw her, but she was okay moving it vertically.
Mhm.
So we'll stop right there, John. And how would you kind of react and think about this patient as you saw her?
Yeah, that was a great overview of the physical exam. So props to the team for doing a very detailed physical exam. I think starting out just looking at the vitals before we jump into the exam, I think we finally get some objective evidence of an infection. Great, we have a fever. Not all fevers are infection. I'll lead off with that. And certainly we also want to consider in the right patient, like autoimmune etiologies. We also want to consider potentially drug fever. But in this situation, it seems with a 103 fever to be somewhat consistent with possible infection. Also being tachycardic, raising concern for possible sepsis as a kind of overreactive immune system in response to a possible infection. But otherwise, in terms of the rest of the vitals are all pretty within normal limits. Fortunately, not hypotensive. Fortunately, no desaturations, and so not worried about any hypoxemia in this situation. And then moving on to the physical exam itself, I think, again, a lot of pertinent negatives: normal abdominal exam, normal neuro exam, normal pulmonary exam. Again, whenever I'm thinking through an infectious etiology, I always want to think of what is the syndrome? What are we exactly going to treat? What are we going to kind of evaluate? And so my questions are always, what is the infectious syndrome we're evaluating for? And again, I think of the big buckets of the common infectious syndromes that you guys come across with, like meningitis, encephalitis, those being CNS, UTIs, pulmonary infections like pneumonias, abdominal abscesses, diarrheal syndromes. And so always I'm encouraging trainees to think through, like, what are we going to define this syndrome as? Because that'll best let us know what kind of diagnostics we need to do, what type of treatment might we need to evaluate for. And so the significant findings were within the MSK skin exam. And so things that were kind of surprising to me is really the spread of whatever this kind of erythematous rash looks like and the extension to the shoulder. And whenever you say limited range of motion, that always triggers in my head is there's some component of septic arthritis, which can often happen either through direct inoculation, for instance, a needle or something going into the joint and seeding some type of bacteria there. Is it some type of endovascular process, for instance, someone with endocarditis or bacteremia that seeds the shoulder? Or could it just be local spread? So they have some kind of skin and soft tissue infection that spreads to a joint and may end up seeding some type of septic arthritis picture in that situation. And so the shoulder exam was certainly alarming and always rings bells in my head. Do we need to talk to rheumatology or ortho to do some type of arthrocentesis to evaluate for septic arthritis? Because that's certainly very life-threatening and potentially can impact mobility in the future. So the shoulder was certainly of alarm to me. And then other things that you kind of discussed about was, prominent erythema without any fluctuance. So this kind of reads to me, I always think of skin and soft tissue infections as non-purulent versus purulent. When I think of purulent infections, I always refer to your physical exam looking for fluctuance, some type of abscess, something that more suggests like an etiology like MRSA, versus something that's non-purulent. So that's really just on the surface of the skin without causing any kind of deeper abscess process. And in those situations, it tends to be more your strep bacteria, which is, again, a colonizer of the skin, but strep tends to cause more of that spreading erythematous non-purulent etiology versus MRSA tends to cause more of that purulent abscess collections. And so some of this erythema that's spreading seems very classic for some type of strep bacteria. And then other things you mentioned, some draining around the biopsy site, which I may entertain possibly sampling if there's enough like purulent drainage, maybe worth trying to get a culture to kind of evaluate for bacterial pathogens. We talked about the shoulder and rash in the groin area. I see some mentions in the chat. The rash in the groin area, I don't know how to kind of connect that to what's going on around the breast and the neck. Sometimes people with like intertriginous candida can happen if just areas of moisture, especially in our obese patients. Sometimes we just have a lot of moisture, skin-on-skin contact, and that can predispose to candidiasis that happens in those areas. That may, in some patients, be an alarm bell for immunocompromising condition like HIV, but in an otherwise obese patient, that could just be kind of intertrigo and some type of candida or some type of fungus associated with just the moisture in that area. And so to summarize, the big things that I'm worried about is some type of skin and soft tissue, potentially some kind of spreading non-purulent strep. And then potentially I'm worried about the shoulder. Do we need to do an arthrocentesis, especially given the limited range of motion? I'd be curious how much of this is new versus does she have some component of lymphedema associated with her breast cancer? Like how much of this is chronic is a question I have in my mind. And then I can go on all these random infectious disease tangents, but other things to consider for sometimes skin and soft tissue infections. We often refer to our gram positives, as I mentioned, with strep and staph. But sometimes, especially after a procedure, we start to worry about maybe gram negatives contributing like a surgical site infection, or in the right kind of patient that goes to the sauna or goes to like, I don't know, if this 73-year-old woman is for some reason going swimming in open lakes or whatever. But water exposure is also something I really ask about. And anyone that has some kind of like wound or some type of spreading erythema, have you been in contact in the sauna, open waters, brackish waters? Because those can predispose to more unusual gram negatives like Pseudomonas, Vibrio, Eromonas. And so those are a long rambling kind of thought process through some of the physical exam findings.
Thank you so much, John. That was awesome. Ali, anything else you wanted to add about the exam? What about the effusion that John was talking about?
I think the only other piece of the exam that I didn't mention is that the erythema spread to the side of her neck, and she was reporting pain with swallowing. This was kind of cool. Her daughter's actually a speech therapist, so she like did a swallow test at home and was like, there's no problem with her swallowing. But she was having pain on the outside of her neck as well, with motion of her neck and then with swallowing as well.
Yeah, I didn't even talk about the neck pain part, but that's a great add-on, and I'm glad that we have, family buy-in. We have a lot of collaboration, multidisciplinary. And so another consideration, especially in someone that has, neck pain that's limiting their range of motion. My question right now is this all related to a skin infection that developed from the skin biopsy, or a little harder to believe, but could she have some kind of like neck or throat process that is somehow spread down? So kind of thinking through where is the primary inoculation of this possible infection. For instance, things like Lemire syndrome, which is like a septic thrombophlebitis caused particularly by anaerobes, but those are types of bacterial infections that kind of originate from the neck, sometimes with some type of viral predisposition. But I'm trying to wonder right now, is it like neck down or kind of the breast up in terms of etiology of this infection? And so curious about potentially moving forward with some imaging would definitely be helpful in getting some labs as a spoiler moving forward. And then we'll start there. I see some mentions about treatment and stuff in the chat, and I'll be sure to address that as we get some more info.
Awesome. Thank you, guys. Yeah, it was very interesting, the dynamic between her and her daughter too, because I'm sure some of us have experienced this when you're in medicine and you have a family member end up in the hospital or need care from doctors. Your mind just starts spinning 1,000 possibilities. And I feel like especially all the CPS people, somebody comes in with chest pain and you're thinking about like TB causing an effusion and all these kinds of things in your family member. So I think that's what was happening with this patient's daughter too. But Ali, yeah, well, let's keep going and let's see if we can get some basic labs.
Okay, cool. So we did get a CBC. Her white count was 15.4. Her hemoglobin was 11.8. Her platelets were 208. We got a chem panel. Her electrolytes were all normal, sodium 135, potassium 3.5, bicarb 26, creatinine 0.7, BUN 19. I already gave you her A1C was 8.5. And then we did have blood cultures prior to initiation of empiric antibiotics. And those were positive for GPCs that later speciated to group B strep.
That's it, John. That's all you get for now.
Awesome. We'll take it. So immediate things that jump out, elevated white count, leukocytosis. Again, not always infection, but in this kind of current syndrome with the fever and tachycardia, it seems pretty suggestive of some type of infection versus sepsis. And then other things, her chem panel, the rest of the labs are largely unremarkable. And certainly the blood culture is growing group B strep seems very consistent with the current picture. Certainly we were suspicious of strep from the get-go in terms of some type of strep organism. I will say group B strep is not as commonly. I usually think of more of a kind of a urogenital pathogen, but it certainly can also be found on the surface of the skin and can be associated with skin and soft tissue infections. Whenever I see a blood culture that's positive, I always talk through it with my trainees. Like, I always wonder, where is the blood culture? Like, where is the culprit pathogen from? Do they have a clinical syndrome consistent with this pathogen? And in certain pathogens, are we worried about it embolizing or causing disease elsewhere that may cause further complications? So those are my usual approach whenever I see a bacteremia. Is this pathogen consistent with the syndrome that makes sense? And is there any concern about this bacteria causing distant disease? And in this setting, group B strep, again, not one of the ones I typically associate. I usually think of more group A strep and some other types of strep being associated with skin and soft tissue infections. But group B strep can be found on the skin. And so I think it does fit kind of the clinical syndrome in terms of skin and soft tissue infections. So that's the source, maybe coming from the skin. It doesn't typically cause additional complications, not a sticky bug like certain types of other strep, like strep viridans or classically Staph aureus. Those can really stick and embolize to any part of the body and cause complications like endocarditis. But group B strep tends to be pretty benign in the sense that it doesn't tend to stick to other parts of the body. And so overall, I think the labs are fairly consistent with our initial kind of pre-test. We were thinking that this may be some type of skin and soft tissue infection, and a strep species is not a surprising find in this situation.
So John, I have a couple questions for you. So honestly, when we got the blood cultures back, I have not seen group B strep that much. The only times I've really seen it is when I've been on the infectious disease service, and all the people, maybe this is just bias, all the people that I saw with group B strep were very sick. But it seems like, you've seen it more often. And I guess like, let's say that the blood cultures came back group A strep or group B strep. Would there be a difference in how sick you thought this patient was or not really?
Yeah, that's a good question. I think there's a lot of variability. I've seen this very commonly or more commonly in like patients that have, diabetic foot infections, and they just have polymicrobial infections related to that. I think between group A versus group B strep, I'll emphasize that all of the strep species are quite variable because they are localized differently on the body. So some strep species are in the oropharynx, some are on the skin, some are in the urogenital tract. And so each of them have a different predilection to the body, and they have a different kind of disease presentations. I worry group A tends to have some other kind of sequelae that we think about. Group A strep particularly could be associated with like necrotizing skin and soft tissue infections, essentially necrotizing fasciitis where there's a lot of toxin production. So honestly, group A strep, the number of times that I've seen it, I honestly have been in more toxic patients with group A strep. Group B strep, I have not seen in very significant necrotizing infections. And so I think the major teaching point there is each strep species is different in the sense that it localizes differently on the body. Each has different presentations and each has different predilections in terms of causing complications. And so think of each strep species as quite different. And a major teaching pearl is that group A strep in particular has a toxin production and can be really associated with necrotizing fasciitis and necrotizing infections.
Awesome. Thanks, John. And, when we're in the ED and thinking about starting antibiotics on people, we always wish we had a John Huang by our side to tell us which antibiotics to start, what kind of imaging to get. So there's been some talk of that in the chat. So we'd love to hear from you, since we have the opportunity to have you this time, on what you might start this patient on and what kind of imaging you'd like for her.
Yeah, absolutely. Always a tricky question. And the general thought process that I've developed as being a fellow is you can always start broader and then you can always narrow as you get more information. And so in this current situation, I'm just trying to think of empiric therapies that would broadly cover my most concerning organisms. And so the different kind of referring back to when I was talking about the different syndromes, like what syndromes are we trying to treat in this situation? Some things that are going through my mind right now is like, I still haven't fully clarified if this is neck down. And if it was neck down, I might be worried about some oral anaerobes in addition to the, typical gram-positive organisms that we would mostly encounter with a skin and soft tissue infection. If it was kind of breast up from the surgical site or from the biopsy site, I'd really just be concerned about staph and strep, and primarily strep in that situation. So good gram-positive coverage is certainly a priority for me in this situation. Other things I'm considering, as I mentioned, is anaerobic coverage. If I'm worried about some kind of Lemierre's or some type of neck infectious process. And then the other consideration that I haven't fully elucidated is, does this patient have septic arthritis? Because that might require more broad empiric antibiotics, broader than just your gram-positive coverage. Because typically with kind of empiric septic arthritis coverage, we include some gram-negative coverage, for instance, with vanc and ceftriaxone, vanc for the gram-positives, ceftriaxone for gram-negative coverage. And so with the information that I have right now, without any additional imaging or kind of elaboration on is there or is there not septic arthritis, I would, and I hate to say it, but I might do kind of a broad therapy, for instance, something like vancomycin, which I don't typically recommend. But given the different buckets that I'm considering, is this septic arthritis? Could this be some type of Lemierre's neck down process rather than just a skin and soft tissue infection from staph and strep? I might do something like vancomycin to cover gram positives, gram negatives, and it has that anaerobic coverage in case we're worried about any kind of oral flora. I think the other consideration that as I'm looking at the data, we have group B strep in the blood cultures, and so very likely that is a contributing pathogen. I don't know if I feel comfortable quite yet doing just directed therapy to group B strep, because this could be polymicrobial from something in the neck. It could be polymicrobial within the shoulder. I think until I get some imaging and get a little bit more familiar with the patient, I might do something like vancomycin to cover more broadly gram positives, gram negatives, and anaerobes, given some possible neck involvement. But that group B strep makes me feel a little bit comfortable potentially narrowing at some point in the near future as we get some more information. And so that was more the therapeutic aspect. In the back of my mind, I'm also thinking, can we get an arthrocentesis? Do we need an arthrocentesis to get some more microbiologic information about the shoulder? And then the last question that has come up quite frequently in the chat is imaging. And so there's no perfect imaging to hit all the areas that I want, like thinking neck, chest, also the shoulder. In general, skin and soft tissue kind of approach, generally I prefer a CT for kind of the soft tissue structures. So a CT head, neck, maybe a CT chest. I'd consider possibly with contrast, both to evaluating for possible thrombophlebitis, and also just to evaluate for any kind of deeper abscess. But that doesn't get perfect characterization of the shoulder. Usually for kind of MSK septic arthritis, we would prefer an MRI. It gives us a little bit more information in terms of the joint space. But I think I would start with some type of CT imaging of the neck and the chest. Particularly, I think I would add contrast just to better evaluate for abscesses or any type of clot or anything that might be in the neck. So I think I would start with vancomycin for therapeutic, for empiric therapy. That might be completely the wrong answer, but I think thinking through it as I'm speaking through it, vancomycin kind of makes sense, and then getting a CT to start with of the head, neck, and chest.
Awesome. Thanks, John. I feel so validated because that is what what we did for our patient. So I'm glad that you also agreed with some broad spectrum in the imaging that we chose. But Ali, I'll let you take it away.
Yeah, it's like you were right there with us. So we did end up deciding to get imaging. This is the final aliquot, so the diagnosis will be revealed. So we did get a CT soft tissue of the neck, and we did get a CT of the chest with contrast for the same reasons. We were worried about abscess. And we found a rim-enhancing complex joint effusion involving the left sternoclavicular joint, concerning for synovitis and possible septic arthritis. There was associated periosteal reaction and tiny erosive osseous changes involving the proximal clavicle, concerning for erosive synovitis. And then there was asymmetrical thickening of the left sternocleidomastoid and left strap muscles, concerning for inflammatory or infective myositis. So our the other piece of imaging that we got, given the species, was we got an echo, first transthoracic, which did not visualize our valves well enough, and then we did get a TEE to make sure we were visualizing the valves well, and there was no endocarditis. So our final diagnosis is strep A galactiae bacteremia with septic arthritis of the SC joint.
Yeah, so I thought this case, we both thought this case was interesting because I've never seen sternoclavicular septic arthritis. But John, I wanted to hear from you what teaching points you have about it, and then we can talk about kind of what ID told us about that particular joint and infections.
Awesome. Great job, Ali, kind of walking through the whole clinical course. Yeah, you guys did an excellent job and agree with all. You didn't even need an ID consultant. You guys kind of nailed it. But kind of the SC joint septic arthritis, I agree. It's a fairly rare kind of syndrome from a septic arthritis standpoint. Usually it kind of, again, as I alluded to, whenever I think of septic arthritis, I think of like, how did that joint get infected? And most commonly it's from like seeding from like traumatic injury or some type of local infiltration of bacteria into the joint space. But another consideration is like, could there have been an endovascular infection or something in the context of the bacteremia? Could it have started with the bacteremia and then seeded the joint? And so in this situation, I mean, given the localization with the left breast and the recent procedure, I seem to somewhat favor that it was just a very profound skin and soft tissue infection in that area that locally infiltrated into the joint space. And so that's where I kind of think the etiology comes through. Again, group B strep tends to not be a particularly sticky bug that would cause endocarditis. And so there's a wonderful figure, I think, in ACC, in one of the cardiovascular journals that like looks at the different risk of endocarditis in the context of different strep species. And I highly recommend you guys refer to that article because each strep species has a different propensity to cause endocarditis, and group B strep tends to be very low on that in that setting. So I don't know if I would necessarily have pushed necessarily for a TEE in this situation. But how I kind of put it all together based on the information that we have is that I think possibly like a complication from this breast biopsy that led to a skin and soft tissue infection with a type of strep species that further spread, and based on local infiltration. And in this right host, like she had a lot of radiation therapy. And so in those situations, sometimes it thins the skin and it has increased propensity for bacteria to kind of translocate in those areas. So I do think that maybe there were some other risk factors that led her to particularly be at risk for these complications. But I think local infiltration of the strep that kind of seeded the local joints, kind of the sternocleidomastoid area, and just continued spread from there, leading to myositis in that area. So in my mind, it all kind of stems from a local skin and soft tissue infection that really kind of blew up. And I'm curious to hear if, after discussion with surgery colleagues or IR colleagues, like the big thing we advocate for from the ID side is, can we get source control of this infection? And if there really is a complex joint effusion, or some other type of rim enhancing lesions, are we able to kind of drain any of these processes? Are we able to wash out any of these joint spaces? Because those are certainly persistent nituses of infection, and I don't know if we can fully cure it with antibiotics without getting adequate source control of the joint space or any of the bones. Like sometimes this will lead to a progressive osteomyelitis, where the infection will further spread to like local structures, including the bone from the joint. And so I certainly would want to discuss with our surgical colleagues to see if there's any possibility of getting adequate source control in terms of washing out these joints or possibly draining, arthrocentesis, any way that we can better source control this infection.
Awesome. Thank you so much, John. And then Allie, can you share what happened next with our patient, and then talk about any teaching points that you learned from this case?
Sure. Yeah, so we did end up consulting IR to see if they could aspirate or wash out the joint space. There was, not a ton of fluid in the space, but we did sort of learn from our ID colleagues that the best way to get source control is to wash out the joint, even if it's a really small effusion that doesn't look like it would give us like good culture data to prove that this is, the bug that was growing in the blood. Since it's a pretty small joint that's not very well vascularized, we were worried about penetration of the antibiotics into the joint space. In the end, there was not enough fluid for us to think it was worth the risk. And given the family's hesitancy after the breast biopsy kind of led to this infection, we ended up opting not to go for it. We ended up discharging her with 6 weeks of antibiotic therapy on levofloxacin. And some of the teaching points that I learned from this case were about sort of like needing to get source control, needing to wash out the joint, even if you're doing many weeks of antibiotic therapy. I learned a little bit about GBS outside of pregnancy. Usually I think strep A galactiae, I think, the sketchy galactic baby, I think of infections, like perinatal infections. But it can also be a source of significant morbidity and mortality in older adults too. Usually conditions that are associated with worse disease include diabetes, malignancy, both of which our patient had, and heart disease. And then often GBS is a polyarticular small joint infection. So when you have these like littler joints involved, like the SC joint or small joints of the hands. So it'll definitely be something that I'm thinking about a lot more.
Awesome. Thank you so much, Allie. John, any last things that you want to share before we jump into teaching points from Dan?
Yeah. Again, great job, guys, with the case, and it was very clear the way you guys presented it, and so strong work. Kind of some final thoughts. I agree. As best we can advocate for source control, sometimes it just can't happen. Like, understandably, these are small joints. You can't just like rip out someone's sternum. And so understandable that you're limited by how well you can control the infection. So I always appreciate our discussions with surgery and IR to kind of best source control in conjunction with what's even feasible. In terms of the antibiotics, I think, again, we started with vancomycin, and I'm not advocating ever to do broad vancomycin for everybody, but I think in this situation, when it was a little bit undifferentiated, like, could there be anaerobes from the throat? Could there be gram-negatives from a surgical site infection? I think in those situations, using broad coverage and then narrowing as we get some additional clinical information is key. And so don't let anyone ever penalize you if you can justify your broad coverage. And so in this situation, it seems like all we've been able to isolate was group B strep, which is it makes sense in this clinical context, coming from the skin, leading to bacteremia, and then also leading to kind of a disseminated or deeper seated infection in the bones and in the skin in that area. And so I agree with we can probably tailor the vancomycin to something just like ceftriaxone, which has great strep coverage, very targeted strep coverage. And then the question always comes up about IV versus PO options. And kind of my teaching point there is that we're getting increasingly comfortable with using good PO options. If someone has a functional gut, I always try to encourage oral options when feasible. Sometimes that can't always happen for, your endocarditis or your Staph aureus bacteremia, but we're getting more and more data that oral works just as well as IV with less complications like PICC line infections or PICC line complications. And so I agree with trying to get her on oral therapy. Whenever I think of oral therapy for some of these more difficult infections, and so 6 weeks of antibiotics seems very appropriate for kind of a septic arthritis, osteomyelitis, bone and joint infection. We need longer courses to kind of eradicate the bacteria in those settings. So certainly would do 6 weeks. And then when I think of the PO options, I usually, in addition to think about coverage, like I want to make sure the oral antibiotic has appropriate coverage for the pathogen, I also want to think about penetration. And so I like the thought that you guys put in levofloxacin. There are certain antibiotics that have great bioavailability, which means great absorption in the gut, and has great penetration, where it's able to reach those deep spaces like bone or even CNS. I'm always thinking, does my oral antibiotic reach the location that I needed to get it to, and does it cover the correct pathogen? And so I think levofloxacin, once you get the susceptibilities back, has great bioavailability, great bone penetration. And for those reasons, I think it's a good option. It does come with, its toxicities, QT prolongation, joint. It can be associated with joint complications, tendon rupture, those kind of things. But I think levofloxacin has great bone penetration as a good option in this situation. Some providers may also be just comfortable with high dose amoxicillin or Augmentin, which doesn't have as good bone penetration, but can also very effectively treat group B strep, which tends to be very susceptible. And so kind of the major summary of those teaching points is whenever you can, try to get patients on oral therapy. And also, when I think of oral therapy, I want to make sure it targets the pathogen correctly. And most importantly, it gets to the site of activity where I need it to get to. So is it able to penetrate the bone? Is it able to get into the urine if I needed to treat a urine infection? And so those are kind of my thought processes about oral antibiotics.
Thank you so much, John. We learned so much today. Felt like having a little consultant in our pocket as we went through this case. We loved having you on, and we would really love to have you on again. Dan, I'll let you take it away with the teaching points.
Yeah, John, I'm not really sure how I'm supposed to summarize all that, man, but it's fine. I will do my best. Okay, so I am just going to briefly hit kind of the main pearls we talked about. So starting from the top, when we approach an HPI, especially from the ID mindset, thinking about the host, what is their immunocompromised state? Do they have HIV? Is there a component of CVID? Are there other factors that are going on that could predispose someone to a specific type of infection? We'll get into that a little bit later, but for this particular patient, skin procedure, biggest things to think about is there an infectious complication, tracking SSTIs, abscess. These things kind of help clue us into what's going on. We also talk a little bit about the scale of immunocompromise. And I think this is a really important distinction that John brought up. Is it innate immune system that's dysregulated, or is it the adaptive immune system? So briefly, innate, we're talking about the skin barrier, neutrophils, macrophages, as opposed to the adaptive immune system, which is T cells, B cells, possibly antibodies, things that need to be activated in order to fight. Moving on, talking briefly about malignancies, differentiating solid organ malignancies from other bloodborne malignancies. Particularly with solid organ malignancies, generally these patients are not as immunosuppressed, mainly in the absence of chemotherapy and potential bone marrow infiltration. And so that's just something for us to keep in mind. Interestingly, there are other things that can predispose patients. For example, a big one we think about is diabetes, namely A1C over the range of 13 to 15%. What we're really focusing on is neutrophil defects. And so that's why these patients can often get fungal infections like mucor, for example, or rhizopus. Additionally, something that I think is really important to always remember, not all fevers are infections. And so it's really, really important to put the clinical context together to make sure we're getting everything right. And then finally, when we're approaching this whole process, things to think about: what is the infectious syndrome we're evaluating for? In other words, what are we trying to figure? Is it a meningitis? Is it a pneumonitis? Is it a CNS process? And number two, why are we seeing the physical exam symptoms that we are? So for example, I think when Ali presented the limited range of motion, that automatically cued John into thinking, is there a potential A, endovascular process, or B, SSTI that's leading to a septic arthritis? And so I think tying those things together is really, really helpful. And then moving on further, we also have a really good schema for an SSTI. So purulent versus non-purulent. Purulent, we think of abscess collection and classically a MRSA or some kind of staph organism, as opposed to a non-purulent, which is more spreading, superficial, erythematous, think strep. Now, importantly, for patients who have potential surgical infections or exposures to sauna, open lakes, brackish water, think about other gram-negative organisms, namely Pseudomonas fibrio erymonis. And then finally, when we're thinking about blood cultures, it's really important to characterize what is the blood culture actually looking for? Is the pathogen that we're seeing consistent with the known process? And we learned that group B strep is fairly benign. However, each strep species is different and localizes differently and has different symptoms. And the big thing for us to take away is group A strep has toxin production and is associated with a necrotizing infection. And finally, another pearl for me was it's okay to start broad and taper as you go. We don't necessarily need to be afraid of starting vancomycin if we think the patient meets criteria. And so for this patient, thinking about imaging-wise, CT for soft tissue, potential contrast to evaluate for thrombophlebitis or a deeper abscess. I think a really important point was when there is a joint space, an MRI can give you a better visualization of what that process is. And then the last thing I want to highlight, since I've been talking for a while, is PO options are increasingly viable for these patients. If they've got an intact gut, if there's good pathogen penetration, and if we're targeting the right organism, we should really consider PO options for these patients. And so that is my best attempt at summarizing everything John said. Thank you guys so much. You guys are incredible.
Dan, that was awesome. I feel like you should be a salesperson for PO antibiotics. You definitely sold me on it. And then just like for some post-credit information, this patient was very, very adorable, one of our favorite patients, and she had a message for everybody here. She said she was super excited that her case was being shared, and she wanted to wish everyone here good luck in whatever they were doing. So that's from her. Thank you all for joining us today. Thanks, John. Thanks, Ali. Thanks everybody for scribing and for teaching points. Great seeing everyone.
Thanks so much, guys. This is
Thanks
wonderful.
for having us.